Hi everybody and welcome to our module on abortion. A spontaneous abortion is also referred to as a miscarriage, or in clinical circles it's often called an SAB for short. And this refers to the loss of a viable uterine pregnancy prior to 20 weeks gestation. Spontaneous abortions most commonly occur in the first trimester, meaning before 12 weeks, and there are a couple of ways that they're identified clinically. In modern practice, we do so much measuring of serum HCG levels that often they're identified in a woman by a falling HCG level on serial testing. In other words, if the level stops rising and begins to fall, that often indicates a spontaneous abortion. They're also often identified early by ultrasound findings that indicate a non-viable uterine pregnancy. When not identified by serial HCG levels or ultrasound findings, the clinical presentation is with vaginal bleeding and pelvic cramping. There are many different potential etiologies for a spontaneous abortion, but I've listed some of the important ones on this slide. High on the list is fetal chromosomal anomalies. This is found in 70% of pregnancy losses. If the baby has missing chromosomes or extra chromosomes, this often leads to a spontaneous abortion. Another important group of causes are anatomic anomalies in the mother. So if the mother's uterus has problems like uterine fibroids, or polyps or septa, these can make implantation problematic and lead to a spontaneous abortion. Sometimes the fertilized egg simply doesn't implant normally, and that leads to an abortion. A spontaneous abortion will also occur if the corpus luteum fails for any reason, because the corpus luteum maintains the pregnancy during the early weeks of gestation. And then beyond these things, there are other causes like torch infections or trauma and many other potential causes. Shown on this slide are some of the important risk factors for spontaneous abortion. First of all, pregnancy loss is more common among older women. Maternal age greater than 35 years is a risk factor for miscarriage. Also, women who have had a prior pregnancy loss are more likely to have another pregnancy loss, and they're at higher risk. Smoking or alcohol consumption increase the risk of spontaneous abortion. And then there are a number of maternal diseases which raise the risk of pregnancy loss. This includes infection in the mother, diabetes, obesity, thyroid disease, or any form of thrombophilia where the mother is prone to developing blood clots. This can potentially lead to spontaneous abortion. When you suspect a woman may have a spontaneous abortion, the workup usually begins with a pelvic exam. If the woman has bleeding, you want to confirm that the bleeding is coming from the cervix, and then you want to assess the cervical os. If it is open, this means loss of pregnancy is very likely. After a pelvic exam, the next test that's usually done is a transvaginal ultrasound. This can look for products of conception in the uterus or elsewhere. It can also assess the fetal heartbeat if the pregnancy is still viable. And then, as I mentioned before, in the modern era, lots of serial HCG testing is done, as well as measurement of progesterone levels. In a viable pregnancy, the HCG level should increase at least 60% over 48 hours. If this isn't happening and the HCG level is falling, that suggests a possible spontaneous abortion. Also, if the progesterone level is low, this usually suggests an abnormal pregnancy, either a failed gestation that will ultimately become a spontaneous abortion, or this can be seen in an ectopic pregnancy. Clinically, spontaneous abortions can be classified based on the woman's symptoms and whether or not the products of conception have completely passed from the body. The easiest subtype of spontaneous abortion to understand is a complete spontaneous abortion, so we'll talk about that first. A complete spontaneous abortion occurs when a woman has a documented intrauterine pregnancy and then develops bleeding and cramping. The cervical os has to be closed and there have to be no products of conception evident by ultrasound, even though the woman earlier had a documented intrauterine pregnancy. And then in addition to these items, there can't be any evidence of ectopic pregnancy. So if a woman meets all of these criteria, then she is said to have had a complete spontaneous abortion. And the management in these cases is generally just supportive care. Sometimes antibiotics are given to prevent endometritis or infection. There's a drug called methylorganavine which can be used. It causes uterine contractions, and this can lower the risk of small amounts of retained tissue or infection, and so this is sometimes also administered. Some of the other clinical abortion subtypes are listed on this table. A threatened abortion basically means that a woman has a viable intrauterine pregnancy, but she has developed bleeding and cramping. The cervical os will be closed, and on transvaginal ultrasound, if the pregnancy is beyond 6 weeks, you'll see a fetal heartbeat, and so you can tell that the pregnancy is still viable despite the bleeding and cramping. We'll talk about the management of this in a minute, but in general, it's with supportive care because the bleeding and cramping may stop or it may progress so that the woman has a complete abortion. An inevitable abortion is when there's bleeding and cramping, but the cervical os is open. By ultrasound, you still see a fetal heartbeat or other evidence of a viable pregnancy, but the open os makes the abortion inevitable, and usually these are not going to go on to become normal pregnancies. In an incomplete or missed abortion, there's no evidence of a viable intrauterine pregnancy. There's no fetal heartbeat, and the products of conception are not deemed to be viable by ultrasound. So in an incomplete abortion, there's bleeding and cramping and open os, and you don't see a fetal heartbeat, and the products of conception are partially expelled from the uterus. That's why it's called incomplete, because they're partially expelled. In a missed abortion, there's bleeding and cramping, but the os has closed, and even though it's closed, there are still products of conception left behind in the uterus. The pregnancy is not viable, there's no fetal heartbeat, but there are products of conception remaining behind despite a closed uterus. This is called a missed abortion. And we'll talk about the management of these three subtypes of abortion, but in general there are surgical options, medical options, or expectant management. So as I said on the last slide, a threatened abortion is when there's bleeding or cramping in early pregnancy, which is before 20 weeks, but the cervical os is closed and the pregnancy is still viable, which usually means that you can see a fetal heartbeat on transvaginal ultrasound. A threatened abortion can resolve or progress to become a spontaneous abortion. The way this is usually managed is by weekly ultrasounds to check the status of the fetus, and also serial HCG measurements to make sure that the HCG level continues to climb, and you do these things until the bleeding resolves. If the bleeding resolves, then the woman can go on to have a healthy baby, but there is an increased risk later in her pregnancy of having either preterm labor or intrauterine growth restriction for the baby. And so basically what these women have is bleeding in early pregnancy that resolves, and there are a couple of common reasons that this happens. One of them is if implantation occurs at the time of menses. Another is bleeding from cervical trauma due to intercourse. And then lastly, there can be a small amount of hemorrhage beneath the chorion as the placenta is developing, and this can also cause early pregnancy bleeding that eventually resolves. For the other types of spontaneous abortion, inevitable, incomplete, or missed, in all of these cases the pregnancy is not viable, and there are a couple of management options. One is a surgical evacuation. This involves a procedure called a dilation and suction curettage, where the products of conception are manually removed by the surgeon. A second option is medical evacuation. This involves administering drugs that will cause the uterus to contract and expel the products of conception. There are two drugs used for this purpose. One is called mifepristone, the other is called misoprostol. Mifepristone is a progesterone antagonist, and it causes the endometrium to degenerate by blocking the effects of progesterone. The thing to know about this drug is it's only dispensed at limited facilities that perform terminations, so in many obstetricians' offices they do not have this drug available. The other option is misoprostol, which is a prostaglandin analog. It causes the uterus to contract. It can only be used in women who are hemodynamically stable with no evidence of hemorrhage or infection, but misoprostol alone will sometimes cause the products of conception to pass. So when available, both of these drugs can be given together, but in many obstetricians' offices they only administer misoprostol. It's less effective, but still effective enough that it often works. And then a final option for women with inevitable, incomplete, or missed abortions is so-called expectant management. This is where you allow natural passage of the products of conception and simply monitor the woman over time. Next, let's talk about a septic abortion. This usually refers to a spontaneous abortion associated with intrauterine infection. It can also be seen in attempts at self-abortion in which bacteria are introduced into the cervix and the uterus. It presents with vaginal bleeding and pelvic cramping similar to other forms of abortion, but the mother will have a fever and there's usually foul-smelling discharge. The treatment is with broad-spectrum antibiotics and then surgical evacuation of the uterus with a procedure called a suction curettage. It's important that you know this word suction, so when there's infection in the uterus, there's an increased risk of uterine perforation. So by using suction, this is less traumatic to the uterus than sharp curettage, so the usual curettage with a blade is not done. Instead, it's a form of curettage called suction. In the video on prenatal care, I talk about prevention of alloimmunization in Rh-negative mothers. But any Rh-negative mother who has a spontaneous abortion is at risk for developing alloimmunization, so she should be administered RhD immune globulin to prevent future development of hemolytic disease of the newborn. Next, let's talk about intrauterine fetal demise, which is also called stillbirth or fetal death. This refers to pregnancy loss after 20 weeks. With intrauterine fetal demise, there's death of the fetus before delivery. If death occurs during delivery, this is called intrapartum demise, and this is a different clinical problem. The way an intrauterine fetal demise can be identified is if the mother notes lack of movement, In addition, the uterus can be small for the gestational age of the fetus because the fetus is not growing any longer. You can also suspect this condition if there's an absence of fetal heart sounds when you listen with the stethoscope. The diagnosis is ultimately made by ultrasound. It will show absence of a fetal heartbeat, confirming that there has been fetal demise. Some of the risk factors are shown on this slide. Most cases have no identifiable etiology. This can occur if there is congenital anomalies present in the baby. This can also occur if there's any cause of fetal growth restriction. Maternal infections, either systemic or in utero, are associated with fetal demise, and so is placental abruption. Many cases of fetal demise occur in mothers who have chronic disease. Fetal demise can also occur if there are accidents associated with the umbilical cord. And then lastly, any women who use drugs, especially crack cocaine is famous for this. This can potentially lead to fetal demise. The management of fetal demise depends on how far along the pregnancy has progressed. If it's before 24 weeks, it's managed with a surgical procedure called dilation and evacuation, a DNE, to remove the fetus from the uterus. After 24 weeks, the safest way to remove the fetus is through induction of labor. This is the preferred method of removing the fetus, even if the baby is in a breech position. Now, having to go through labor and delivery of a fetus that has died is extremely traumatic for families and mothers. So you don't have to do this immediately. You can allow a delay until the patient is ready to have labor induced. This doesn't have to be done immediately on identification of fetal demise. The only thing that needs to be avoided is prolonged retention of the fetus over many weeks can lead to disseminated intravascular coagulation. So you don't want this degree of delay to occur, but once you tell the mother, you can give her hours or days to get ready, and then you can do the induction of labor and remove the fetus that has died. There's a standard workup that's often done after a case of fetal demise. First of all, there's a fetal autopsy and an examination of the placenta for placental problems that could have led to fetal demise. A drug screen is often done on the mother, and fetal chromosome testing is also usually done. Testing can be done for the antiphospholipid syndrome because women who have this often initially present with recurrent fetal demise or spontaneous abortions. And then lastly, testing can be done for fetal-maternal hemorrhage. Fetal-maternal hemorrhage refers to bleeding from the fetus without trauma or abruption, and if there's a large hemorrhage, this can present as fetal death. Basically, the baby loses blood and dies, but there's no vaginal bleeding or other evidence of hemorrhage. When this happens, fetal red cells will get into the maternal circulation, and they can be identified by a test called the Kleihauer-Betke acid elution assay, or the Kleihauer-Betke test. This is a test that identifies red cells in the maternal circulation. It does this by detecting hemoglobin F in fetal red cells. And the results are reported as a percentage of fetal red cells in the maternal circulation. And so if this percentage is very high, it suggests that the mother had fetal-maternal hemorrhage as a cause of fetal demise. An alternative test that is sometimes used is flow cytometry. This uses monoclonal antibodies to identify hemoglobin F, but it's the same principle, looking for fetal red cells in the maternal circulation as evidence of fetal-maternal hemorrhage. The definition of recurrent pregnancy loss is 3 or more consecutive pregnancy losses. And there's a long list of potential causes. Some of the important ones are shown in this table from the White Coat Companion. Anatomic problems with the uterus can cause recurrent pregnancy loss. Women can have polyps or fibroids or adhesions. We'll talk about cervical insufficiency in a minute in this video. Genetic problems in the mother or father can lead to recurrent pregnancy loss. So if either parent has aneuploidy, this can cause pregnancy loss. One of the classic causes is a parent who has a balanced or Robertsonian translocation. This is a genetic abnormality that leads to no clinical features in the carrier, but it can lead to recurrent pregnancy losses from genetic problems in the fetus. Antiphospholipid syndrome is a classic cause of recurrent pregnancy loss. There are a number of endocrine causes, and then women who have inherited or acquired hypercoagulable states are also at increased risk for pregnancy loss. The workup of recurrent pregnancy loss is complex and extensive, but on this slide I've shown a few of the common tests that are performed. The first one is imaging of the uterus. There are 2 ways this is commonly done. The first is called hysterosalpingography. This uses a fluoroscope to take an image of the uterus and fallopian tubes to look for structural abnormalities. An alternative method is sonohysterography. This uses ultrasound of the uterus when it's filled with saline contrast so that you can take a picture of the structure of the uterine cavity. A karyotype of the parents can be done to look for aneuploidy. Anticardiolipin antibodies and lupus anticoagulant testing can be done to look for the antiphospholipid syndrome. And then a TSH is often measured because mothers who are hyper or hypothyroid can have recurrent pregnancy loss. Next, let's talk about cervical insufficiency. This refers to the inability of the cervix to retain pregnancy in the second trimester. Basically, as the pregnancy grows in the second trimester, if the cervix is weak, this can lead to recurrent pregnancy losses. So women who have this condition will develop recurrent second trimester pregnancy losses, and usually they have very mild symptoms associated with the pregnancy losses. They don't have significant bleeding, cramping, or contractions. And this is in contrast to spontaneous abortion, which we talked about earlier. That usually occurs before 20 weeks, and it's usually associated with cramping and contractions. There are a couple of different ways to make the diagnosis of cervical insufficiency. First of all, it can be made based on a woman's obstetric history. A woman with 2 or more consecutive second trimester pregnancy losses associated with no or mild symptoms has cervical insufficiency. There are also ultrasound criteria that can be used. If the woman is in the second trimester of pregnancy and the cervical length is less than 25 millimeters, plus she has a history of a prior loss or preterm delivery in the second trimester, then this meets criteria for cervical insufficiency. And the idea here is that when the cervical length is short, that increases the risk of cervical insufficiency. So a short cervix less than 25 plus a history of pregnancy loss makes the diagnosis. And then lastly, the diagnosis can be made by physical exam. If a woman in the second trimester has a dilated and effaced cervix, this makes the diagnosis. Sometimes you can even see the fetal membranes and fetal parts bulging through the dilated cervix. This is all consistent with cervical insufficiency. There are a couple of treatments that can be used to prevent pregnancy loss in women who have cervical insufficiency. The first one is cerclage. This is shown in the image on the screen here. This involves stabilizing and closing the cervix using stitching and sutures. The other option is vaginal progesterone. And then beyond these things, women are usually told to avoid exercise during pregnancy because they have a weak cervix. They don't want to do anything that puts extra pressure and force on that cervix. I'll finish with one slide on elective abortion. This refers to a woman choosing to terminate an otherwise viable pregnancy. Elective abortion was legalized in the United States in 1973 in the landmark Supreme Court case of Roe v. Wade. Generally, elective abortion is performed before 24 weeks, which is considered to be the marker of when the fetus becomes viable. What this means is that extrauterine survival before 24 weeks is unlikely, whereas after 24 weeks it's more likely. So for this reason, elective abortions are generally performed before 24 weeks when the fetus is not thought to yet be viable in most cases. You will sometimes hear the expression late-term abortion. This refers to an elective abortion performed in 21 to 24 weeks, right up until the time of fetal viability. There are medical and surgical options available for elective abortion. Medical abortion, for example, prior to 10 weeks of gestation, can be done using mifepristone and misoprostol, which we talked about earlier. And that concludes our module on abortion.